So good morning to one and all. So I'll be presenting to one is abstract and one is an article. So first I'll go with the abstract. So this is the effect of ovarian ablation or OFS, what we say in general. The effect of OFS on the recurrence and the survival. And this is a very nicely done patient level meta-analysis over almost 15,000 patients data. And this is restricted to premenopausal women, and it includes 25 randomized trial. So initially they started with 27, but they could not get data on two of the trials, which was initially 19,000 patients, but now they have come down to 25 trials where they have the data, and they published it over a 15,000 patient. This is a very important data because we have two specific group which we do encounter in our clinical practice. The A group, or the first one, is a very simple group where no chemotherapy, or patient had received chemotherapy but still remains premenopausal. This is very straightforward. And the other group is premenopausal before chemotherapy, but there is uncertainty after. So this is something what we see in clinical practice too. So this is the first slide of the primary the recurrence risk, and we can see from the first graph that this definitely there is an advantage of giving OFS, and there is a 15 years gain of almost 10% with the use of OFS. In the B group, again, there is a 15-year gain which is seen, but it is numerically very small. It is just 1.3%. Coming further to split up to understand which subgroup is going to get benefited or which subtype of patients are going to do good. First of all, we'll see the age pattern, and in the B group, when we see the age pattern, it is very clear that patients who are less than 45 are actually getting more benefit than the patients who are beyond 45 years. Similarly, in A group, we can see that most of them are getting benefit, but when we see further, we can understand the patient who are having the age of less than 45, they are having more 15-year gain of 11% versus the patients who are a decade older, they are getting a little less, but definitely good 7% benefit. Coming to the mortality, which was the second part, the survival, we can see from the first graph there is a clear evidence of improvement in the 20-year gain by almost 11% on mortality. Death without recurrence is numerically 2%, a little bit smaller than what we expected, but all cause mortality again is almost 12% better. Coming to the recurrence in node negative and node positive, node negative, there is an improvement of 8% at 15 years gain. In node positive, the same thing has improved to almost 12%. So definitely the patients who are node positive are getting better advantage with the use of OFS. Coming to the recurrence with the use of tamoxifen, yes or no. So the first graph shows where there is no tamoxifen used, and the patients received only OFS. Most of them had ablation either in the form of radiation, and we can see the delta is much higher. It is almost touching to 18%. The delta is quite big, and this is what was one of the focus of the authors. But when we use tamoxifen, the delta becomes smaller. It is somewhere close to 5%. But we can focus when the patient do get tamoxifen plus OFS, the recurrence are the minimal. It is 25%, whereas if they don't get anything, it is 56%. So almost more than half of your patients are going to recur. Coming to the ovarian ablation versus ovarian suppression part, and we can see that both are giving good benefit, but the better benefit is with the ovarian ablation. However, the patient who received tamoxifen in this group was only 20%, mind about that. And ovarian suppression, almost everybody, almost close to 86% patient did receive tamoxifen, and here the difference we can see that it was 15% with ablation, and with suppression it was 6%. So definitely very good numbers, 15,000 patient data, nicely collected data and analyzed. Definitely it is something which we want it in our clinical practice. Question in my mind that when I went through the abstract, I could not see much use of taxane. So I don't know whether the use of taxane will have good or bad effect on the recurrence and survival, or basically to prove whether OFS was advantageous or not. And use of AI and OFS combination, will it have some different kind of benefit? So this is to the question, maybe during the panel we'll come to know. So what they concluded, that premenopausal women, whether known or unknown or uncertainty, with age less than 45 definitely are the ones who are going to get benefit. Node positive patients again are the one who have to get benefit. The delta of OFS without tamoxifen was good, but what I understand that when we combine both of them, the recurrence score is the least. Coming to the second, which is the original article, this is basically an update of the ESTRA trial. Initially, they had presented the 5-year, and now this is the 8-year follow-up. Similar group of patient, premenopausal woman, adding tamoxifen and ovarian suppression versus tamoxifen, whether it has made any difference. Sorry. So study design is very simple. Premenopausal woman. Here they have put a age cutoff of less than or equal to 45 years. So we know that these are the patients who are going to get benefit. ER positive, stage 1 to 3, have finished all their definitive surgery, chemotherapy before, and now they are going to go for the maintenance. Ovarian function was evaluated by doing FSH at the baseline, and it was checked every 6 months for 2 years. Those patients who are having amenorrhea for 2 years, we understand they are postmenopausal, and they had excluded those patients. So this was a simple 1:1 randomization to receive tamoxifen single agent versus tamoxifen plus OFS in the form of Goserli. The main primary endpoint was DFS, and the main secondary endpoint was the OS. We can see from this graph the DFS is showing improvement when we use tamoxifen plus OFS, and the improvement is there in both whether it is the time since the enrollment or the time since randomization, the random assignment. Obviously the random assignment with the period is little bit higher by around 2%. But when we come to the OS, we do see there is numerically advantage of 1 or less than 1%. Again, this is, you can say that clinically may be beneficial, but definitely not statistically significant. This is a further few points where the primary endpoint was seen, and what they can understand that local, regional or distal recurrence, all of them are having advantage when we can combine tamoxifen plus OFS. Again, this is a similar thing, and this is actually showing how the different patient groups are going to do. So again, good number. This was almost 1200 patients trial, 600 in each arm. Nicely analyzed. This is something again we want to use it in our practice to most of our patients, because this is a big group of young patients with ERPR positive, and these are non-metastatic patients. We want them to live as long as possible. Here what I understand that this was using OFS for 2 years. So now we have some data. Obviously we know that there is data for 5 years of OFS, and we have 10 years of data of tamoxifen. How does this influence in our clinical practice? We will come to know during our panel. So what they conclude that premenopausal women should receive tamoxifen and ovarian suppression at least for 2 years. That's what I understand. So thank you for the patient listening, and I'll stop here.